you very much for this kind introduction. I will try to be very brief, and I know that the attention span is probably already overloaded because what Winnie Slee has already described is somehow new, but at the same time old. This is what I'm trying to do with this presentation as well. And we have a question mark here, but the main question mark is why not global tinnitus treatment yet? We know that we have many interventions, but none of this is universally accepted. So I will try to answer this question, to address this question. I know it's very difficult and I will not give the answer, I have to say in advance, but there is a long list of issues here. So I would like to present some of them. There is a big heterogeneity in the pathophysiology of tinnitus, and I think one of the few things that we all agree is that there is not one particular anatomical site that is fully and absolutely responsible for the presence of tinnitus. I have to thank my friend Winnie for this slide, and my inspirer at the same time, Winnie. He presented a version, I think it was in Nottingham, and to trigger a lot of thoughts and discussions that ended up in the Unity project. So what this tries to say that we have more than 10, close to 15 possible anatomical sites, and one of them could not function well, and or more than one of them, and or also the transitions between one or more places. So probably it's some thousands of possible combinations, and this could go on forever in a personalized manner. We have heterogeneity of phenotype. I will not say more because Winnie already covered some of the topic. On top of fluctuations, we know that some patients find tinnitus really bothersome and they could even have suicidal tendencies just by tinnitus, and some of them could not bother at all, and they just answer in epidemiological studies or in the generic medical history for other causes that can lead them to the hospital or healthcare services, and they would not ask help for tinnitus. Intermittent versus constant is the roller coaster that Winnie just presented, and also sometimes we're lost in some details because we only focus when we use DHI on handicap, but there is also loudness, which is considered very important, as we already saw, and also its duration, again, that can vary a lot, and also that makes patients different because some of them could only experience tinnitus in absolute silence before they sleep, but still be very annoyed, and vice versa. Some patients can have during all the day, but not that annoyed. On top of this, you have to consider comorbidities like sleep disorders that could be correlated with tinnitus and depression, and you have to weight the correlation between these comorbidities and tinnitus and whether they are part of these comorbidities or they are just circulating with these comorbidities independently. 90% of tinnitus patients also have various degrees of hearing loss. However, I think we all agree that an audiogram cannot predict neither the presence of tinnitus nor the loudness and the annoyance caused and the distress caused by tinnitus. So again, we should also take this parameter into consideration. And there is an ongoing discussion, and you can find the relevant publication about tinnitus disorder with many authors, including myself and Winnie. And we have to address the question whether we think that there is an organized disorder be applied for an entity, a clinical entity. Of course, we have a lot of interventions, and different interventions target different aspects already described. And we should also take into consideration that these need different outcome measures. This was one of the outputs of the TINET cost actions for tinnitus. There was a great work by the relevant working group, and we know that depending on what we target, we should use the relevant outcome measures. Another output of the TINET cost action was multidisciplinary European guidelines for tinnitus. They involved more than 100 experts in the field from Europe, and they have been published 3-4 years ago now, and they are still ongoing. We will have to update it at some point. And then we made an online study in experts across Europe with hundreds of respondents, more than 400, in order to see what's the current status of the application of basic guidelines for tinnitus in Europe. So I must just cherry picking here some, let's say, outliers, but at the same time indicative of how the situation is across Europe. You can find in the BMJ, you can see the relevant link. So roughly 80% in Eastern countries, because we divided the answers in Southern, Eastern, and Western countries, for the sake of analysis, said that nasal endoscopy is essential and they do consider first in tinnitus assessment. At the same time, only 1% consider minimum masking level necessary. And if you see the guidelines, this, of course, recommended as not necessary, but highly recommended. And approximately 1/3 of the whole data set of the participants across Europe stated that they only have less than 15 minutes to spend with each one of tinnitus patients, which everybody understands is too little. At the same time, CBT, although considered the most effective therapy, was only available in roughly 15 in the Eastern countries and 1/3 in Northern countries. What is more important, in my humble opinion, is that even in the North, there's a considerable amount of experts who stated that they do not use any kind of questionnaire to validate their patients, and this is majority in the Eastern countries. So probably even if the guidelines state something, this does not mean that this is applied in the clinical field. On top of this, we have to consider methodological insufficiencies, even in the highest possible level of evidence, which is RCTs, and some of them we cannot avoid because tinnitus is fluctuating. I think we all know this by now. There is also difficulty in some cases in blinding. It's very easy to blind a trial for a pill, for a medication. It's very difficult to blind a clinical RCT with hearing aids because participants in the control group will immediately recognize that they are not held by the hearing aid. Also, as already stated, there are a lot of comorbidities, and we have to take them into consideration on top of fluctuation. And also, sometimes patients complain both for hearing loss and tinnitus. There is a subgroup expressing that thinks that the cause of the hearing loss is tinnitus, or when tinnitus is worse, the hearing is worse as well, and so forth. So this requires attention as well. And also, it's difficult to provide the best available treatment in control group. We have a lot of placebo control trials. However, current recommendations require that even the control group should be provided with an acceptable therapy. So these are intrinsic things that we cannot avoid, but there is also issues in design of the studies. There is a relatively recent systematic review. You can find the link here. It's from our group and Winnie as well. And we investigated the past 10 years, 74, if I'm not mistaken, RCTs in the tinnitus field. Only 10 had more than 100 participants, and the median was 54. Most of them used too many outcome measures, 44% over 3. And this is not as bad as that only 14 define primary outcome measure. So the rest 50 just use the outcome measure without choosing the primary. Also, the majority did not provide power analysis. And roughly 1 out of 3 defined a minimum threshold of annoyance in the inclusion criteria. So only 1 out of 3 included patients that have, for instance, DHI over 18 or over 24 or whatever. So this means that there's great variance, and even people potentially with non-bothersome tinnitus could be included. Of course, there is the issue of motivation here. And roughly 1/3 provided hearing loss range inclusion criteria. This again is very important because it influences a lot, even CBT. If people have severe hearing loss, they cannot listen to the psychologist. And also there's a great variance in follow-up time and inadequate data for long-term results. So in order to try to address why not tinnitus treatment yet, we have a suboptimal adherence to clinical recommendations, which even considered optimal are based on studies with considerable methodological insufficiencies. And still, this is a field that has significant intrinsic constraints on itself. So we're not in the best available situation right now. During the past few years, Earth has changed through technology. Our lives have changed a lot. We're just sitting in our offices right now across the globe and communicate through internet. This is 21st century. What I described a couple of slides earlier was the insufficiencies of studies that were designed according to what 20th century standards were. So very briefly, everybody knows we have two or more groups. We provide something to one group, something different to another group. We randomize in order to be not sure, but as sure as possible, that all confounders, including age, gender, socioeconomic status, comorbidities, and so forth, are as equally as possible distributed among these two or more groups. And then we say, is treatment A efficacy significantly better in statistical manner from treatment B? If yes, then we forget about treatment B and we only recommend treatment A. Of course, this is too simplistic, but it's a rough way to explain to your students. We forget, though, that there could be the case that for a subgroup of patients of treatment B would be better than treatment A for the many reasons, including profiling. So 21st century, instead of hypothesis-driven analysis, has also to add, and not solely, of course, rely on, but to add data-driven analysis. And this has changed because this now is possible for many reasons. And main reason probably is technology that we use anyway, every day, and also technology dedicated to tinnitus recording, monitoring, intervention. So how can technology help? Ecological momentary assessments. You saw the applications previously. You don't have memory or recall bias, at least at some points. You might have contribution, population bias, because one patient could choose the default value in his mobile application. But this is at least something you can know, discuss, and even organize your analysis based on this. And there are ways to escape this. We also have open data. Winnie earlier mentioned about the pandemic. Now we know even if we have forgotten the everyday fluctuations of pandemic indicators in our country, they're still there in data, and we can correlate those fluctuations with any open data, including weather, political changes, war, or whatever. We also can handle big data. The way we learn includes taxonomy. Taxonomy is the way that we distribute things in different classes, different clusters. So there are a lot of different and somehow contradicting descriptions and definitions about big data. But in order to define in the medical field, I would choose probably the simplest one, not necessarily the most accurate. The simplest answer is that big data is big data that you cannot analyze with traditional methods. Or to state it even simpler, big data cannot be populated in an Excel file or even in a SPSS file. So they need different manipulation. I've been involved in previous big data projects for hearing aids and hearing loss. We managed to gather more than 100 million data points. It was impossible, of course, to analyze them traditionally. This also requires, but also offers opportunity for multidisciplinary approach. What does it mean? We can communicate with other disciplines, both in the medical field and outside. We use mobile applications both for data collection and intervention. We can have data analysis that is far beyond what we are used to. And the aim, the target, I don't think we are there yet, is personalized medicine. What does it mean? We can have continuous feedback. If something doesn't go well, we can have a red flag right after. And of course, these applications go on and on better because they apply machine learning techniques, and the more data they collect, the better they perform. Why is tinnitus a good candidate for technology? Fluctuating course, already said about it. Comorbidities, we need to wait, and this is difficult with the current methods we have. Life events can be objectively recorded. We can even have a continuous monitoring of noise and know whether it is adequate to mask tinnitus at a certain time point. And we also have variability in treatment response. The same treatment has made very different response in different patients, and this means that we can have pattern recognition. Sorry. And what is emerging need is to profile patients. Personalized medicine wants to answer the question whether treatment A is better than treatment B for a particular patient profile, not in general as a mean in two different groups. I would like to thank my colleague and friend Birgit for giving me the permission to give you one of the images of a recent publication about patient profiling. They used 14 different questionnaires, and based on the answers and also some demographics and clinical also data, they divided 4 different groups: avoidant, psychosomatic, somatic, and distress group. So they have different characteristics and probably a different course in the tinnitus and different treatment response. Having all this in mind, we applied for a EU fund 4 years ago. This was from the kickoff meeting that happened 3 years ago in Athens. And we used interventions that were considered adequate from the European guidelines. And there was an idea to say that some of them were ear-mediated and some of them brain-mediated, including sound therapy, hearing aids, structural counseling, which was the very first time is as it says, structurally offered through an application, and also CBT. So what we did, we unified existing databases, retrospective data. Then we conducted an RCT, one of the biggest in the field, with more than 450 participants by now, in order not only to compare the efficacy of different interventions, but also to collect data in a structured way in order to feed this data in a decision support system. How is a decision support system, a DSS, created? First of all, retrospective data that are not necessarily parameterized the same way. And we include data analysts that can target feature selection. What does it mean? It could be the case that different factors, for instance, just one threshold in one frequency in an audiogram or minimum masking level or history of other diseases, could be determinative, could be a prognostic factor that we could rely on for treatment response, so that we know that this group of patients might have better response to a certain treatment. We used random forests. I will very conceptually try to introduce you to this concept. It is an algorithm, but not just one. It runs many, many times. It is somehow democratic. And of course, repetition and machine learning improves the outcome. By now we are in a very initial phases, and even more sophisticated techniques will be applied. But where we stand, because we expect in 5 months to stop, we expect even better performance. So just to make a concept about this, what we have used to not only rely on medical history, etymological data and questionnaires, we have also used the tinnitus characteristics, tinometry, and electrophysiological data, including ABR and AMLR. Each and every patient underwent this, and most of the patients also provided blood samples for analysis, both for genes and biomarkers. And the expected output, as I said, is A, the personalized proposal for extra examinations, laboratory examinations if needed, because it takes time and money. And of course, what is considered optimal treatment or combination of treatment. And this could be the case that the DSS, and you can see here some screenshots of how we enter the data. And this is how stage of noise collects data, and also the dedicated application provides sound therapy with notched music mainly, but not only, and also structured counseling with 12 different chapters provided intervention. And this is conceptually what we expected from AMLR mainly, but ABR also. And this is the first announcement I can make because the paper has been submitted, that we have managed to correlate both latencies and amplitudes of 3 out of 4 AMLR waves with tinnitus distress in terms of THI score. So this is not something that says something definitive at the time, but at least it's a good indicator to keep on searching towards this direction. A possible way to go for the future, and this is my last slide, is profiling and personalized medicine, to wait for comorbidities, address EMA, and collect as big data as we can in order to improve. Thank you very much.